is an opportunity for addressing the access and affordability challenges that patients and families face when they're confronted with any kind of complex or chronic illness. And what's particularly exciting, and I think we took away from the conversation yesterday, is as hard as these challenges are and as frustrating as they can be for families and the people who are working to help support them in meeting their constellation of concerns, there is help that's proven, tested, and true available, but it's not available everywhere. And so I think in terms of what today's focus is, we're going to dive deeper with opportunities to influence how we can spread the word about the needs that people have in defining them and describing them with people's chosen words that describes what's the constellation of concerns that matter to be most in getting addressed, and think about how can there be services available to support those needs that achieve better outcomes for people, both in terms of their well-being health-wise, but also their financial well-being and their emotional well-being. So today is about a deeper dive with the services that are available, the opportunities for influencing the change that we know needs to happen to make needs navigation a recognized, understood, what we would say standard of practice as an essential part of healthcare. Now, that's not to say that the health system needs to necessarily take charge of all of this. In fact, it probably shouldn't. There needs to be sort of a hand-in-glove opportunity to match up the folks who are best able to support financial and social needs, assessments and referrals and help with people in the health system that are there to focus on disease-directed treatment. When you get those together, you're going to have more equitable access, better affordability, and better outcomes for health systems, but most importantly for people. And that's what we're about in research, in policy, in advocacy. And you're going to hear in the different sessions today about some of the meatier opportunities we have for influencing how change happens to make needs navigation, to address people's social concerns, their financial concerns, a part of mainstream support and care. So with that, we're going to cover a couple of housekeeping bits first with my colleague, Mary, and then we're going to dive into a panel that I think everyone will really enjoy, focused on some of the ways that we as an organization, our partners, and all of you who volunteer in different advocacy capacities have made a difference already in influencing the change we know needs to happen and what we can do next. So Mary, if you could go through housekeeping. I'll also thank first our very generous sponsors who made Patient Congress possible. They're listed here, shown on the screen, and we're so grateful and indebted for the support of our sponsors, but also all of you who are in our audience, who make a real difference every day for the experiences and the access and affordability that patients and families need. Mary?
Thank you so much, Rebecca, and thank you all so much for joining us today for our second day of Patient Congress. To go over some general housekeeping before we begin, please submit any questions that you may have into the Q&A box on the bottom of your screen. We also have closed captioning available as well for this session. And if you are experiencing any technical difficulties, please go ahead and email the email that you see on the screen, npafevents@npaf.org. And if you could, just to get some extra excitement this morning, let us know where you're joining us from in the chat and if you are affiliated with any organizations as well. So we're going to go ahead and go into the agenda for the day as well before we kick off our session. So as Rebecca Kirch had mentioned a little bit earlier, our first session of the day is going to be centered around person-centered research, discussing how to engage patients, caregivers, and researchers as well within the health sciences space. Our second session of the day, beginning at 12:45, we're going to be discussing co-creating programs with community partners and advocates. We're going to have a short break and then come back to session 3, which is broken up into 2 parts. So if you registered for session 3A, you were able to join that session. If you registered for session 3B, as they are happening concurrently, you can go ahead and go into that room. And then we will close out the day discussing how we're able to collect evidence to support needs navigation. So without further ado, I will go ahead and pass this off to Rebecca.
Thanks, Mary. And it's fun. We have a couple Rebeccas. So it's my privilege to introduce Rebecca Angove, who is leading this next panel session, which we hope to be very engaging. Yesterday was a great start. The bar was set high, and today will only get better. And I will also make an important plug at the end of today. Please do fill out the evaluation using the link that will pop up as you close out. We really do take people's feedback and input and insights very seriously in terms of how we shape up these events for the future. I will turn to Rebecca Angove, my colleague on the screen, and her illustrious panel, which you will describe, Rebecca. So please take it away, and thanks for a great day ahead.
Thanks, Rebecca. Yeah, it does get confusing. Too many Rebeccas, although can there ever be too many Rebeccas? So I am joined with my great colleagues, Gwen Darien, who is the EVP of Patient Advocacy and Engagement at the National Patient Advocate Foundation, as well as Kate Gallagher, who is the VP of Health Services Research at Patient Advocate Foundation. And together with myself, we are going to have a bit of a roundtable discussion about patient engagement and research and projects, and how both PAF and NPAF have included and partnered with patients to make sure that the work we do is informed by and really driven by, and at many times co-created by patients and the patient experience. There will be time to ask some questions at the end, but if you have questions while we're chatting, please put them in the chat, and we will absolutely get to as many as we can. But Gwen, I thought we could start with you, and if you could just talk a little bit about the importance of patient and caregivers and influencing and informing the work that NPAF does. You know, what programs are they involved in, and how are they being involved?
I thought the host was unmuting all of us. Kate, we all have to unmute. Anyway, thank you, Rebecca. Kate, great to see you, and great to be on a panel together to talk about patient research that really centers patients and really focuses on multi-stakeholder partnerships. So before we just kind of dive into some of the specific projects, I just want to step back a minute and talk about why this has been the foundation of patient advocacy for so many years, which was to put patients in the center, patients, families, communities in the center of research, because ultimately, of course, patients, families, and communities are the ones who receive care, are the ones who decide, as we talked about yesterday, whose values and whose goals should inform the care that they receive and the care that they deserve. So in order to make sure that through research and through engagement, that we achieve goals and outcomes that are important to patients and families, we have to ensure that their voices are there from the very, very beginning. And so I think that, as I think about my kind of 25-year advocacy journey, it's pretty hard. It's amazing to believe it's been 25 years now. I think about, I have worked in different kinds of research advocacy, from clinical research advocacy to healthcare system research advocacy, to also as well as psychosocial research advocacy. And in all of those, the best research is the research that's done that puts every stakeholder and includes the expertise of every stakeholder in that research. And so today I'll talk a little bit about one project that we've been working on at NPAF, which is a project that we're doing in collaboration with my friend and colleague, Sandy Suffian at the University of Illinois, Chicago Medical School, which is looking at how we engage patients virtually in the CF community, which Sandy is a part of, and the breast cancer community, which I'm a part of, to set up research questions on women's health and sexual and reproductive health. And in that research project, we're actually setting up the questions and then convening the lab that will develop the research protocols and develop them further into a research plan and a research program.
So Gwen, can you maybe give us a few examples of exactly how patients are being involved in informing it, just so some members of our audience who haven't been involved in projects give kind of a feel of what that really looks like?
Absolutely. So this project, I mean, this project has it's sort of, what I love about it is it turns the general process of research on its head. It sort of flips it. So the first group that we convened was, we call it the breast cancer cohort team. And they have developed and they've convened meetings of women with breast cancer, women who are survivors of breast cancer, to look at to develop and look at different aspects of the impact of breast cancer on women's health, particularly sexual and reproductive health. And as many of us know who've had breast cancer and have had loved ones who've had breast cancer, that is a huge impact for women with breast cancer. Is what happens on women's health. Everything from families to body image to sexuality to things that we don't necessarily want to talk about outside of our groups of people with like experience. So what we've done is that we start with meetings that we've convened. We've now done 6 of them, that we bring together patients and we bring together a topic. And the women with breast cancer they develop the research questions together among themselves in a safe space. And then we vote on what questions are the most important questions to that entire group. And those questions will then be put forward to a lab that we're calling the Letter Lab, which is the lab to engage transdisciplinary research. And that lab will take what women who with breast cancer and survivors have identified as the things that are the most important to them in terms of outcomes, and turn those into research questions and develop research protocols that we can look for funding. So all of the research and all of the questions are derived from women's experiences and things that are important for women. So I'll just say, from a personal experience, oftentimes people make decisions on, let's say, breast conserving surgery based on cosmetics. They don't necessarily make it based on what women are going to need, what it changes in their quality of life, how they are, what happens after that surgery. So when I was making a decision about surgery for my breast cancer, my surgeon recommended I have a bilateral mastectomy because of cosmetic issues, because of what would happen if I had a recurrence. I said, well, what's my chance of recurrence? Well, 2%. Well, then why would I, so those kinds of questions, because I'm an advocate, was able to reframe the questions in ways that were important to me, rather than just looking at it from the way that might have been important to somebody who didn't have breast cancer. What's the difference between recovering from surgery that is 14 hours as opposed to 8 hours? There are just so many issues that people who have gone through this really understand what the impact of their choices are. So our role in this project and our role in patient-centered outcomes research, I think, is to ensure that people make decisions based on evidence that is important to them and based on their goals and their values, so that they don't just make a decision based on something so that they take in the whole person, they take in their whole lives. They don't think of it from one specific frame or another. We all live our lives. We do not live linear lives. There are multiple paths that intersect, and there are clinical reasons, there are family reasons, there are quality of life reasons, there are work reasons that we make all of these decisions. So that's what we're trying to do, is look at it from perspective of a person rather than the perspective of what might be a clinical research question.
Yeah, those are such great
Recording in progress.
Thanks so much for sharing, Gwen. I want to pull back a little bit, because what I love about having both Kate and Gwen on this panel is that Kate is our PAF resident epidemiologist, and she works with big data, so less one-on-one in advocacy work like Gwen does. So Kate, you're working with, and I say big data, it's not huge, but we at PAF serve 120,000 patients a year. We collect a lot of information, and we hear a lot of things from our patients, and we also do some survey work. And I was wondering how you, as both an epidemiologist, you lead our data team, but you're also really involved in initiatives in collecting the patient voice and making sure that voice and perspective informs PAF, our work, and also the wider healthcare ecosystem. Can you kind of just talk a little bit about that and the importance of knowing the challenges and needs that patients have, maybe on that larger scale, a way that you work with it?
Yeah, absolutely. So one of the most interesting things about, I think, the data that we have and that we collect at PAF is that it does make this really nice circle and cycle. So I get to see a lot of our programmatic data, which is the data that it's predominantly collected through our case management and our navigation programs, our high touch programs. Often I get to see some of it at an aggregate level. I get to see some of it at the individual level. And we tease out concepts from what the case managers tell us they hear from patients, what we see is trending in this data. And this is how we develop a lot of our survey initiatives. Often we will pull in our colleagues, over at NPAF, or we'll reach out to others in different departments at PAF to design some of these different survey tools. But once they're launched, they allow us to gather an additional layer of information that can be paired with what we see programmatically. And it allows us to answer questions, as well as to collect thematic data. And Rebecca, this is something that you have a tendency to handle a little bit more than I do, but a lot of those open-ended questions, it's always really interesting to see how diverse, but then also how homogeneous those responses can sometimes be. And again, it's data that drives questions, that drives data, that drives questions.
Yeah, I love that you talk about the themes that emerge in some of those research projects, because it leads into some of the things that Gwen's working on, right? So we'll, for example, send out an email, and you're right, the things that everybody is saying is really interesting, right? Because there's something there. If everybody's saying the same thing or having a similar experience, that there's usually something there. But then when you look at the anomalies, right, or the outliers, or the one-offs, usually that's also kind of this nugget of something unique is happening, and how can we make sure that doesn't become a trend if it's a challenge, or how can we figure out how or why this experience matters in the bigger picture. So you're right, kind of those bigger data projects absolutely feeds into those kind of smaller exploratory projects, and vice versa. It's great seeing how kind of the cycle, right? The research cycle. I know that patient engagement in research is something that is becoming more and more widespread. And, for our audience, I just want to share that when we talk about research, we're really talking about research that spans, kind of the entire healthcare continuum. So it's not just clinical research, although there is patient engagement involved in clinical trials. And FDA funded work and a lot of, industry work, what you think of a lot when you say research. But research is also small scale studies into how to translate findings into the clinical world. It is, lifestyle, psychosocial. So, that experience that patients have with the disease and their condition that often happens, in academic settings. So there's a lot of work, kind of the research, the term research really spans everything that is being collected and explored about, patients and healthcare. I mean, Kate, the work you do is research, right? With your survey work and kind of exploring the data. And I think there's definitely a movement to engage patients more, especially in the early phases of this work. It's definitely one of my messages and one of my soapboxes whenever I get a chance to talk. I was wondering if you both maybe individually could talk a little bit about what opportunities you see, both at PAF and some of the projects that you're involved in, Kate, and at NPAF, Gwen, that you're involved with, to really increase patient and caregiver involvement in the research projects you're working on or see as upcoming.
Yeah, I mean, Rebecca, I think with a lot of this survey work, I have a concept or an idea of what I see in data. And, we do have a lot of patients who they're not one-offs. They have a tendency to repetitively be involved with PAF for whatever sort of healthcare information, education, navigation that they're seeking. And, I think this idea of building a network of activated patients who can contribute to projects that we're thinking about doing is really exciting. I know that's something that you have been in the process of building out in a couple of different ways. And I believe also we'll be doing a focus group later on today. But to me, that's one of the most exciting things and things that I think are needed. I think having kind of like these organized and activated, and again, on the end side, I think that Gwen's team does a really great job of that activating, especially through their volunteer network, and also dissemination. I think that that's something that they're really, really, really good at doing.
Gwen, you're on mute.
We were being muted on, and I thought we were being muted and unmuted automatically. You would think, I say this after 18 months of this, I would know how to do this, but no. So in the next session, Chris Wilson and I will describe one of the projects that we've done sort of very much in depth around conversations about cost of care and measurements about cost of care. But what I'll say in this session is that so many things that we do and all of the initiatives that we look at are really that we undertake are really informed by the experiences of the patients that PAF serves. And those patients are primarily underinsured. They're from traditionally marginalized communities. They're patients with serious and chronic illnesses. They're people who do not have access to equitable and affordable healthcare. So everything that we do, both internally and externally, is really very much driven by the values of the organization, which is that everyone deserves access to equitable, affordable, and quality care. And the other thing that we do that is very much part of the value of the whole organization is that healthcare is not just clinical care. Healthcare is care of the whole person. Cost of care are not just cost of your doctor's visits or clinical care. It's also childcare costs, it's opportunity costs, it's cost of daily living, it's the food you need, how many people take medication that they need to take with food. So much of what we do is reliant on good nutrition. And then the other thing that we do is we also have focused a lot on the case manager experience and sort of what we're learning from the case managers and aggregating that in terms of our patients. So one example that actually both Rebecca and Kate worked on as a project we did with friend and colleague Vince Bonham at the NIH about equitable access to genomic and personalized medicine. And in that, some of the things that we learned from that project, because we interviewed case managers rather than patients, were things that we've carried through. So one of the things we learned was that the extent to which our case managers help patients learn how to be self-advocates, because the self-advocacy skills that they build through case management really are not just about that particular moment, but they are about building skills for as they're interacting with the care system. I won't just say the healthcare system. The other thing that we learned was the extent to which case managers talk about clinical trials as an option for receiving certain kinds of care. Now, they don't match people with trials, they don't sell or promote clinical trials, but they talk about that as an option. One of the other things we've learned is that was mentioned a little bit yesterday is and Kate and Rebecca mentioned it earlier today, is the notion of shared decision-making and how patients and families want to be involved in care. And there definitely is a continuum, but if you look at the continuum, there's a very small percentage on one end who wants to make all the decisions. There's a very small percentage on another end that wants their healthcare provider to make the decision, but the majority of people are in the middle, where they want to make informed decisions and they want to participate in the shared decision-making process. And the only way that will be, the only way that we will do that and we will have the outcomes satisfying to patients is if the decisions are made based on the outcomes that patients care about and that are important to patients. So that's one of the reasons why patient-centered outcomes research is such a critical way and methodology of doing research.
You know, Gwen, I'm so glad you bring up those points. I know one thing that we're trying to do as we were building out our patient network, the work that we're doing through the Institute to really bring in future opportunities to expand and formalize the patient role, not only in the research and the work of PAF, but also with our partners. I think it's so important that we always try to do better and understand what we're not seeing, what we're not asking, our gaps, because only patients know their experience, only patients know what we're missing. And I think, as Kate was talking, I think expanding, we do a great job, I think, at PAF and MPAF of including patients, but we can always do better. And I'm even thinking, it would be great as we continue to involve more and more patients and caregivers in our work to really explore those, the gaps. What aren't we asking? What are we missing? Because so often we ask about the things that are top of mind that our case managers are talking about, our navigators are talking about, or our colleagues are talking about, or the researchers are talking about. And, and our patients give us great feedback on that. But we don't do enough pausing to ask, what are we missing, right? What are we being asked about? And that's a place we could do more.
Well, and I think the corollary to that, as we're, one of the things that we all have been working on very much over, I think, particularly the past year, I've been working on principles of equity and inclusion in PCOR research, is who's not at the table, who built the table. So it's not just what we're not asking patients, but it's also who isn't at the table and how we can identify those, that we have to look around the table. We don't have to just listen to and make sure that we are very intentional in creating this ethos of diversity.
So that is a good call to action. When we email you or reach out and tell you we need your voice, we really do, because we need everybody around the table. So that's my plug for the day. I want to keep us a few minutes for Q&A. I promised the audience they would have time for questions. So Mary, can you jump in with what's going on in the chat?
Yes, of course. One of the questions that we received is, in your experience, How do researchers create an environment where patients and caregivers feel valued and safe?
I have lots of thoughts, but who wants to take that one?
I think that, well, I'll just start because I also can see, there's another comment that came in, which is also similar to this. So one of the ways to really start out is to start out with a really clear idea of what the roles and responsibilities are, and with a clear leveling of respect for everybody across the table. So one of the things that I will say makes me crazy, and has for my 25 years as an advocate, is that if we're around the table and there is a doctor at the table, they will call them Dr. So-and-so. If there's a patient, they'll call me Gwen. So there isn't that same equivalent respect given to people who are around the table. And that's just a signifier of respect. But everybody's role has to be valued, and there has to be open discussion around those values. And there has to be a sense from the beginning of what everybody's roles and responsibilities are going to be, what their compensation is going to be, if it's a funded study, how much time people will be expected to spend, and how decision making is done. So not just how we're going to listen to you, but how we're going to create decisions and how we're going to feed that back to you and create a real learning research enterprise, as opposed to just a one directional research enterprise.
Yeah, and I think researchers are getting better at this. There's more training out there, and we have to realize that for a lot of researchers, this is a new way to do the work. And I've seen some real real success where patients and caregivers kind of learn what their role could or should be. They do a lot of that homework and legwork, and then essentially make, I don't want to say demands, but, kind of set the expectation to the team that this is how you engage patients. This is how you engage me. And really patients and caregivers, once they learn themselves, can really help teach those research teams. And there's lots of online resources, for training, and there's more resources out there. But sometimes you have to teach up.
Yeah, but also I think there's the other thing that we can't forget, which is that there's a mutual compact. So if you're a patient and you're an advocate and you agree to be part of a project, you also have responsibility and accountability to the project. So it's everybody who's on the team has accountability to the other members of the team.
Thank you. And another question that we received in the chat, what are some tips for patients and caregivers serving in an advisory capacity that have not yet taken part in the research process?
So I'm going to use this as a plug for some of the work the Institute is doing. There's a lot of really great resources that can help ready you, both trainings and just tip sheets. And I'm actually involved in a project with Mary and Kate, sending out messages to patients, helping kind of ready them to be part of research teams and advisory groups. So my best advice, without going through a formal training or having kind of a peer coach, if you know a patient that's done it before, is always don't be afraid to speak up and really have the confidence that you're there for a reason. Your expertise matters, and they don't know what you know, and they need you there. Gwen, Kate, do y'all have, or even Mary, you're on that project too. Do you guys have any thoughts?
I would say physicians need to, or researchers need to understand that nothing will ever replace the lived experience. You can have a concept of how something should go, but you can never replace what that patient can contribute actually having gone through that experience. So
I would certainly echo all of those sentiments. I think that also just making sure that it's clear at the beginning when patients and caregivers enter these spaces and these projects, that it is articulated that their experience is expertise. And that's the best training that could ever be given on this type of research project. So we have 2 more questions. One is super interesting. This is a similar one that we received yesterday. How would you let patients and caregivers know the results of research you do, and why is that important?
So I'll jump on that one. The sharing, I think, of results back to contributors is at times one of the biggest challenges. One of the things that we've started doing, at least at PAF, is for all of the survey work, Rebecca and I, and usually a few others, we go through all of the results that we've generated, and we actually create infographics and a 1 to 2 page kind of synopsis, basically reiterating to the patient who's taken the time to participate in our surveys, because at times they can be lengthy, thanking them and actually showing them, in aggregate, this is what your voice contributed to. So that's something that we've been working on. I think researchers who are doing work in communities, in populations, need to be really cognizant of their platforms for dissemination that are not peer-reviewed journals. And those are just as important, if not more important.
Thank you. And I'm sorry, Gwen, did you?
Yeah, I think that there's, and this is something that researchers and advocates have been talking about for a long time. There really is a moral compact that everybody makes when they engage in research, whether it's clinical research or health services research or psychosocial research. And so one of the parts of the moral compact of researchers is that they're not just going into communities and taking from communities and leaving, that they actually need to go, and communities our partner communities, they ask all the time, don't just come in and leave. Don't just come in and take what you need and leave. So as advocates, as researchers, as part of this enterprise, we really need to fulfill our part of this moral compact. And however it's delivered back, one of the ways to figure that out is to ask people how they want the results and what they want from results. But it is one of our responsibilities. So and Chris and I will talk more about this in our upcoming session. But that was one of the kind of founding values of what we did for this project that we're going to talk about. The other thing I just wanted to mention is that we have a really very rich advocacy training program, patient advocacy training program at NPAF, and it is about multiple different. It's a sequential program, and it's about many different kinds of advocacy, backgrounds in advocacy, and it is for people who want to really dig deeper into what it means to be a patient advocate and all the different kinds of patient advocacy that are out there. That is on the NPAF website. And so I encourage everybody who's interested in learning more about all different kinds of advocacy, including patient-centered outcomes, research advocacy, to really go into that and explore that program.
Thank you so much. And there is one more question we have left, but before that, we did receive a comment earlier about time commitment surrounding joining projects. So this, I think, would be a fairly quick one to answer. How is that sort of articulated when individuals join research projects?
Yeah, Mary, that's a really, good question and comments. Very quickly, it really depends on the project, but those expectations should be shared with you as a patient or caregiver upfront. It's okay to ask if they're not shared. And I've been on projects where the time commitment is as little as 10 minutes because they just need a group of patients to do a survey to prioritize research topics, or it could be as intensive as a couple hours or more a week. So it really is dependent on the project, but also researchers are fairly flexible and will work with you. So there can be some negotiation. And oftentimes there's a memo of understanding or some sort of contract-like agreement between researchers and patients. And so that's all spelled out upfront, and both people should abide by, what's agreed upon.
Mm-hmm. And I'll just add one more thing from the patient advocacy perspective, and been somebody who's been asked to be on that side. I think that it's a sign of respect for the patient advocates and caregivers that you're bringing in, that you actually outline what their duties and responsibilities are, and think about the kind of time commitment there's going to be, because we try in everything that we do at PAF and NPAF to be very clear about what the expectations are, how much time it's going to take, the minimum, the maximum, and really lay it out before people say yes, before people commit. And that, it's sort of like when your mother told you when you were younger, don't be late. When you're going out to meet somebody for dinner, don't be late, because you're not respecting them and you're not respecting their time. Same thing with research. Don't respect people's time, respect people's expertise. Think about who you're asking to be at the table, and what kind of table manners we all want to have at that table.
Thank you so much. I know we're coming really close to time. So this is our final one. So in a virtual world, how would a sample collaboration between client and caregiver be if the care involves or is based on client needs? What does it look like trying to fill that gap?
So I think I understand this question. It's, I think from an engagement perspective, and this is not, unfortunately, this isn't related to, say, caregiving directly, but from an engagement perspective, it has been challenging, because a lot of the work that we used to do in person, in real time, in real life, has been put on hold, and we've been doing these Zoom meetings. Which people love them or hate them. But that being said, there has been some success because more people, because of proximity, not needing to travel, there's been an opportunity to really engage a more diverse group of patients and caregivers by virtue of not needing to travel or take time away from the house or out of the house. So I think that's supported a lot more caregiver involvement in some of these projects. Gwen, Kate, do you have anything to add?
So I think there are multiple things to add. I mean, there, as we all have probably seen, lots of conversations about what's going to happen when we can gather together more, and what's going to happen when there are more options for receiving care or getting together. And I think there is, right now we have an opportunity to learn from what we've done over the past year and a half. Some of it has been incredibly successful. I will say, as Rebecca mentioned earlier, we have been able to bring people into our programs that we weren't able to bring into our programs before. We were able to bring in a colleague from Alaska who's Alaska Native, who I could never have flown in for a program. But at the same time, just the idea of healing touch has changed so much. And healing touch can also be the healing touch of being in a room together and being in a community together. But that notion doesn't really come across in terms of on the screen, but you can make communities. And that was one of the reasons why we were so excited about doing this project with Sandy Suffian at the University of Illinois, Chicago, because CF patients cannot gather in a room together because they risk cross infection. And it is, so we wanted to see if that would work with breast cancer patients, if they would create the same kind of relationships and generate these same kind of ideas when they weren't in the same room together. And I think we've done a pretty good job, but we also see where the limitations are. So there are lots and lots of lessons to be learned. And there are also lessons to be learned from things that didn't work. And that's the other thing that I would encourage people to do. We always want to learn from what worked, but we should also not think of something not working as a failure. It is just a way of learning how to do something differently.
Thank you so much. And thank you all for joining us this session. And thank you to our panelists and all the insightful questions that you all forwarded this session. Up next, we're going to begin our second session of the day called Co-Creating Programs with Community Partners and Associates.
All right. Hopefully everyone can hear me. Good afternoon. Thank you all so much for joining and staying on. That was a great kickoff to day 2, and you are going to hear more a continued dialogue around what was discussed previously in co-creating programs with community partners and advocates. I am Jamie Trotter. Many of you know me. I am the manager of patient advocacy and engagement with the National Patient Advocate Foundation. And I'm here with my teammates and colleagues, Gwen Darian, who you heard from in the previous session, along with Chris Wilson. All right, so just to kick off, I want to remind you of some housekeeping notes. Please submit your questions into the Q&A box on the control panel. Closed captioning will be available for this session, and the materials will be emailed to you for this session at the conclusion of the day. If you experience any technical difficulties, we ask that you please email npaf-events@npaf.org. And please let us know in the chat where you're joining us from. Patient Congress, we like to be in person, but this is the second year that we're virtual, so we do want to have that some kind of level of connection to you. And if you're following along with us on social media, we ask that you use the hashtag Health Needs Navigation to join the conversation. I also want to continue and thank our sponsors for making these 3 days possible. And with that, I will turn it over to Gwen.
Thank you, Jamie. And before we start, because I said earlier that we were going to talk, Chris and I were going to talk about one of the projects that we did co-created with community partners, community and advocacy partners. I just want to acknowledge that Jamie was the third member of this very vital team for this project. And Jamie, everything that you're hearing about, Jamie was as involved as Chris and I were in developing this project. So thank you to Jamie as well. And she's going to come back and ask and moderate some of the questions. So I'm also hoping that I could impose on her if she wanted to add anything into the answers as well. So just a little background, and then I'm going to frame this up a little bit and then turn it over to Chris to really go through this project that we did that we think is that was a model for us and that really embodied so many of our values and so many of our goals for co-creating programs with our patient and community partners. So just a little background on how I came to advocacy. I know certainly most of our volunteers and many people on this webinar know that I have been working in advocacy for 25 years. I am a 3-time cancer survivor, and I came to advocacy because of my first experience being diagnosed as a young adult. And one of the things that I think about, that I've been thinking about a lot, because I've been thinking about these as I'm coming up on 25 years of doing advocacy, I think about, hold on one second, I'm sorry, I did not share my slides. And I need to do that. Share screen. No, that's not it. There we go. Can we see them?
Put them on slideshow if you can.
I am going to put them on slideshow. Okay, there we go. sorry, I am very sorry that I said I was absolutely ready to do sharing slides, and clearly I'm not. But one of the values of patient advocacy that I think you've probably heard as a theme throughout this program is something that came out of the disability rights community, which is nothing about me without me. And over the years that has evolved, and it's come to mean different things. We used to say that we wanted to bring the patient voice to the table. Now we want to say we want to bring patient voices. We certainly want to, and everything that we've done and everything that I've done with that we do at NPAF and that we do externally, centers the patients and the caregiver voices and community voices. And one way to really achieve the centering of those voices is to co-create programs so that we don't just go into a community, do something and leave, and do something that is answering questions that we want to answer, but that we really go in and we develop a program with members of the community, and we don't leave when we're finished. We create an ongoing and sustained relationship. So what you're going to hear about from Chris and me today is a program that we did with partners in the Mississippi Delta, including our great friend and colleague and advocate, Tammy Taylor, and in Chicago at the University of Illinois Cancer Center with our partners there, as well as a number of our advocate partners there. In Mississippi, we worked with Tammy Taylor and with Freddie White Johnson, who is the founder of the Fannie Lou Hamer Cancer Foundation. So I'm going to turn it over to Chris to walk through this program and give you one of our what I think is one of the models that I believe that I can say that three of us are the most proud of as projects that we've worked on in the last few years together. So Chris, just tell me when to go to the next one.
That was a good move there.
Yes.
Yeah, I'm going to have to do the next slide thing since Gwen is the master of the slides today. Thank you. I think this session is going to seem almost like a continuation of our last session. That it's going to be a very seamless segue from one to the other. And we're going to try to take a little deeper dive into, we use words like co-creating, but that doesn't really mean anything unless you really define what it is and how it works and what you mean by it. It's just another kind of weight-bearing, jargony kind of word, but it has real meaning when we work in our communities and with our communities and with you. Always love to begin with a quote. It's the literary type in me. I can't help myself. And I kind of like this one. Creativity is intelligence having fun. And I want to just stress that as we do these programs, as we think about partnerships, as we think about even research, we really shouldn't lose sight of the fact that we are really creating these contacts and we really should be having some fun with them. We should never forget about that. So let's talk for a little bit about what it means to put together a program, to co-create a program. And let's sort of think about, ideas, inspiration, but also implementation. Good programs are sort of equal parts of each, I think. So next slide. Okay, so let's start with what does it mean? First of all, when you create a program with somebody, you really, and we've been talking about this for the last 45 minutes and maybe forever, we really want to develop and sustain a meaningful partnership. We really want to work with people and individuals who are deeply rooted in their communities. And one thing I want to stress, and I'm going to keep coming back to this, is that we're not talking about they when we're talking about people rooted in their communities. We're talking about you, because you in many ways are our community. And when we come to you and we work with you, we are working with you as part of the community. So this isn't just about when you go out into your communities and do programs. It's also how we work with you and how we want to interact with you as we move forward. It's really important that we involve our partners at every step of the way, from conceptualizing to implementation and evaluation. I think all of us know from one way or another, whether it's programs, whether in some part of life, what it's like when somebody just comes to you and says, this is what we're going to do, this is how we're going to do it, and you don't really get a say. And in the past, it was very common, and it still is a little bit common, but not as much, for groups that were planning programs with community partners to sort of develop almost a kind of a checklist. Okay, we have our patient advocate, but not really to involve those people meaningfully in things, just to sort of almost let them be kind of window dressing. And so when I say involve people, I mean really from the beginning to the middle to the end. Very important to define and communicate roles. People need to know what they're going to do. This is sort of an off-topic example, but when I was watching the Olympics over the summer, and they were interviewing one of the women's volleyball players, and the women's volleyball team was very good. The interviewer said, "What was the most important thing to you that your coach could do?" And the woman said, "We just needed to know what our roles were. Even if we didn't really love our roles, we needed to know what our roles were." So that's very important. And I'm going to also keep harping on this. Prepare yourself and your partner for everything. So the next set of issues is perhaps even more important. I mean, we talk a lot about cultural differences and about, well, back one, we went too fast. And we all know that it's important, and we all know that there are different cultural types of issues. But I think we need to understand that that's a very broad-based view, and that we also really need to avoid assuming things about the partners that we want to engage with. The example that Gwen used of the cystic fibrosis community, I mean, even if we know somebody who has cystic fibrosis, we really don't know what those people experience. We really don't know what it means to have a disease that is constantly with you all of your life, that may take your life, that means you can't travel, that means that restricts so many of the things you can do, that structures your time and your whole experience. So it's not just ethnic or social differences. Sometimes it's a difference in the patient's experience of a disease. I see this a lot with caregivers. Everybody kind of assumes that they know what caregivers are going through or what caregivers think, and we don't. Or I think of another, well, I'll give you a kind of a personal example. This is kind of a simple one, actually. You can see it now. I was raised in the North, and I tend to talk fast and to sort of expect people to follow at my pace. And as we have worked with groups in the South, I have found that that's not the way it works often, that they talk more slowly, that they need more time to tell their stories and to feel comfortable in their circumstances. So, I mean, these cultural differences can be very, very diverse and very widespread, and they also can be very important in helping us to determine what's a good partnership and what isn't. Always listen. There's such a tendency to sort of want to sort of tell people and to have the answers, but we learn so much more when we listen, and I mean actively listen, really, really let ourselves hear what the other people are saying, not just what they're saying, but how they're saying it. So that's really critical. And we've talked about this. Elevate and give patient and caregivers and advocates their voices. Let them speak up. Let them speak in the ways that are comfortable to them. So other one's a little more practical. A couple of years ago, I was at a meeting, and there was a woman, she was an advocate from central Pennsylvania, whose child had a serious disease. And I said something to her about that she was great and would she consider participating in one of our programs. And she said, you know, my time counts too. I have children, I have other obligations. People expect me to do things, and nobody ever offers me an honorarium. She said, I know you're paid for your time. And she wasn't being nasty or aggressive about it. She was just pointing out that her time was valuable. So since then, we have really tried very hard to make sure that when it is possible, and that we actually write this into our planning, that we make it, that we are able to provide an honorarium or stipend or something for either the individual or the organization we're working with. You can't always do it, but whenever you can, it's just something not to overlook. And then finally, follow up, not just the one and out. Gwen talked about that, but ongoing communication. So now let's talk a little bit about the project that we actually did. It's kind of interesting because this was also a research project, so it fits in very well with what you were talking about in the last section. This was funded by the Robert Wood Johnson Foundation. It was a follow-up to a lot of work that we had done with them and with other groups on talking about the cost of care, which turns out to be a pretty multifaceted, complex kind of subject when it comes to how you actually do it. I mean, it's pretty easy to talk about how much healthcare costs. It's another thing to figure out how you implement those conversations, how you integrate them into clinical conversations. What do you do about them? I mean, once you have them. So our role was a very specific role, very well suited to our organization, was to define and measure the patient perspective, not really on talking about the cost of care, but on what kinds of measurement tools would be effective in doing this. Now, patients are very interested in talking about the cost of care. That is not a problem, getting patients to talk about how much their care cost, or what kind of obstacles exist. Getting them to talk about measurement and screening and those kinds of things is not so interesting. It's not so. That was kind of a challenge. How can we involve them, collaborate with them, get them to really focus on this topic and make it work? So next. Gwen already told you, these were our partners. The University of Illinois Patient Brigade, Candace Henley from the Blue Hat Foundation, Freddie White Johnson from the Fannie Lou Hamer Cancer Foundation in the Mississippi Delta, and Tammy Taylor, who is a great person and a long time NPAF advocate, who was then living in Mississippi but has now moved to Wisconsin. A little change of environment there. So the first, and I'll go fairly quickly through these because we do want to save some time for questions. It really helps if you don't try to start something, or if you're really trying to do a kind of a complex project, that you have some kind of established working relationship. You've already talked to people, you know them a little bit, you know what they're about, and that you've developed that level of mutual trust. That's important. I mean, you can't start things kind of a cold relationship, but it's a lot easier if you have some kind of working relationship as you go into developing a true co-created project. You want your partners to be diverse and inclusive. You want them rooted in and knowledgeable about their community. And you want to make sure that they have the bandwidth, to be capable and willing to do the work that you're asking them to do. So then the second thing is really agree on what it is that you want on both sides. Talk it over, listen to each other, understand. I mean, when we did this project with the Chicago and Mississippi people, we said to them, we really want you to identify the participants, and we want you to recruit those people, and we want you to let them understand what this is all about. So we asked them to do that because they knew who their people were. We agreed on compensation. We did actually have really quite reasonable stipends. We communicated. You have to be flexible. Sometimes people don't move as fast as you think they are going to, or they don't do things the same way that you do. And I think it's all part of really co-creating, is understanding that it's not always going to go the way you think it should go at the moment you think it should happen. And then write it down so everybody understands it. Otherwise, that's how misunderstandings happen. You want to have ongoing discussions, and you want to make sure that there's a project leader, that there's somebody or a coordinator, and that the people that we showed you were the people who were willing to take on the leadership, and they already had very much established leadership roles in their communities. So what did we do? We knew we wanted to talk about cost of care. We knew we wanted to do specific issues, and we knew we had specific deliverables that we had to come up with for our research grant. So we chose a number of key participants, and we did in-depth interviews with these people. Now, I should note this was all done virtually because we had actually planned to go to Mississippi and Chicago in March of 2020, and that it rapidly became clear that wasn't going to happen, and so we had to do this all in a virtual environment. We identified our partners, and we briefed all the session participants in advance. We told them what we were going to do. We were going to have a kind of a talking session, a kind of a community meeting with 10 to 15 people. We were going to provide them in advance. We did a little webinar for them that just kind of laid out the basics. What does it mean to have a cost of care discussion? What's the screening measure? Why is this important? We sent them written materials in advance. And we, of course, prepared our own discussion outline in advance. So we did a lot of work up front, so that people, when they came to our Zoom session, they didn't just frankly think it was a free-for-all. They knew that we had particular things we wanted to talk about. We did get great participants, wonderful people, really interested, They knew what they were doing. They were interested. They were well prepared. We had guided discussions that were really focused around 6 or 7 key points that we needed to address for the grant. But we also gave our participants the room to speak freely about what was important to them. It was very interesting. Gwen will talk to this a little bit later. But there were significant differences between the group in Mississippi and the group in Chicago, even though all the participants were primarily Black or Latino. But regardless, I mean, you can't assume that just because people kind of look like each other that they think like each other. In Mississippi, where there's been a lot of emphasis, and particularly in the COVID era, healthcare is really hard to come by. It's not just that people can't afford it; they can't find it. The hospitals are closing. It's really difficult. I mean, and people also suffer from such high levels of poverty that they frequently can't even think about healthcare. In Chicago, people also definitely experience social determinants of health factors that interfere with their ability to get healthcare, but they were much more actively participating and demanding, not demanding, but they expected higher levels of care and expected more interaction with their healthcare providers. So that was really interesting. During the Zoom sessions, we tried to keep it interactive. We had the discussion, we did polling things, we did use little video clips from our interviews to sort of help stimulate the discussion. And at the end, we said to each person, what was important to you about this meeting? What was good about it? What worked? What did you come away with? And we gave each person in the group an opportunity. And it was really interesting what they came up with. I mean, one woman said, just being able to talk about this gives us hope. Next. And then finally, we need follow-up. And we hear this over and over. Gwen alluded to it in the last session. People say, please don't come in here and do your research and then just disappear. We're tired of that. We're on to you. We don't want to be part of those groups anymore. So little things. Gwen is just great at this. Gwen is an amazing thank you note writer. She's really good. We did a full written report, which was available to our partners. And we continued. The people that we showed you as our partners are people we're continuing to work with and continuing to interact with and continuing to plan programs with. And then at sort of the other end of this thing, we wrote up a 2-part blog post for Academy Health on the project process and its outcomes, so that we're reporting to all the people, all the stakeholders, all the participants who are involved in what we were doing. So that's how we did the project. Gwen, do you want to chime in here? I'm talking too much here.
Yes, I think I will. I think that many of the, thank you, Chris, because we could probably go on and talk about this project for a very long time. It was something that we were incredibly, I think was a really great model for what we were trying to achieve that matched our mission and our values. And as Chris said, when we did the discussion, we did it really as it was a guided discussion, but it was a guided discussion that was guided by the participants, and the questions were developed in partnership with the partners who in each of the communities that we worked with. So it was a very, very multi-layered process. The other thing we learned from this, and the other opportunity, we talked about this a little bit at our in the last session, was because we ended up having to do virtual at very much the last minute. We were able to do things that we might not have done before. So we did the webinars beforehand. We did pre-work together. And so we did pre-work that meant that when we were together, we were really maximizing our time together. We weren't using it to bring everybody up to speed on what we were talking about. We asked people to look at these webinars. And then we also did, we had done an earlier focus group, and a lot of our volunteer advocates have participated in that. And we did a few, as Chris said, we did some video clips of our volunteers talking about what was important to them as they were thinking about conversations about cost of care and how to measure the outcomes of cost of care. So I think most of these lessons learned, Chris has already alluded to. It's a very, very rich learning experience from every perspective. I think that if you don't learn something every day when you're working with people, then you're not really listening to what they're saying to you, and you're not looking and you're not listening. We can achieve our goals while listening and respecting what is important to our partners, because our goals are larger goals, not just the goals of NPAF or the 3 people that you see on the screen or the funder or other partners. Of course, we always need to avoid assumptions. We've been talking about that. One of the huge differences between Mississippi and Illinois is that Mississippi is a non-Medicaid expansion state, and Illinois is an expansion state. That makes that's another thing to really talk about for another day. And then Melissa asked me to put up another slide. I'm going to have to figure out how I can do that. And let me just finish this. So the other lessons learned was respecting time and compensating people, and making sure that you create a long-term relationship. Listening really is everything. Seeing is everything. You can't know other people unless you respect them, trust them, and listen to them. So I'm going to go back. We're running out of time here, but I wanted to just give you 2 quotes from 2 people in the program, and then I'll go back and put up that slide. So in the Mississippi Delta, the cost of care spilled over into the central household bills. This is from one of our, obviously one of our participants. They're unable to pay their bills because they're trying to take care of their doctor's visits. They're going to neglect a bill trying to take care of their health, or they're going to neglect their health, trying to take care of their health. And when I first read that, I thought, is that a typo? They're going to neglect their health, trying to take care of their health. But in fact, it is not a typo. Taking care of somebody's health can cause them to actually neglect their health because of the incredible barriers and burdens of accessing healthcare in that community. Then from Chicago, this was a woman who said she was connected with a doctor, and the doctor asked her, and the doctor went to her and said, "What is this? Is this cost efficient for you? Is this something that I can do?" We talked a lot about whether we wanted all visits bundled in one, whether you didn't want things to be bundled in one, what that meant in terms of parking and babysitting and elder care. And then she asked, what kind of resources would I need to feel comfortable? Because she said, I never would have brought that up. I don't come from that kind of community. And so one of the things that people often say is that patients need to find their voice. But I think equally important is that patients have to be invited to talk about what's important to them, invited to use their voice. And we can't just assume that we can't put the responsibility of this on patients alone. It is a mutual responsibility. It's a mutual relationship. It's a relationship built upon trust and trustworthiness. So I think, is this what I'm supposed to be? Is this the slide that Melissa wanted? Steps
I think
one.
she wanted you to go through 1 through 4 again, but we can, of course, send those slides out as well. I mean, we can make them all available, so you don't have to do screenshots or anything. We'll make sure that you get them all.
Okay. So Jamie, is there anything that we missed that you want? I'm just putting you on the spot. Is there anything that we missed that you want to add? It was I think it was one of the first really big projects you did. You started working on this the day you joined the team.
Yeah, no, I've just been here smiling, thinking about some of the memories from sort of the transition that we had to do for this project due to COVID, and how resilient, the participants and the organizers of each of these respective communities, they really stepped up and they were great. So I think that just goes back to one of the earlier points that Chris mentioned, is really valuing and really, pouring into the working relationships that you already established, because that's what's going to make these programs successful. And it really was, I mean, we just were sort of the conduit, but they really came together and used their voices and had the initiative that they wanted to see some of these things brought to light and really take took ownership of that project. So I was just reminiscing on how fabulous of a time it was, despite the fact that we could not be gathered together in person.
Yeah, I just want to add that I mean, I've never been to the Mississippi Delta. I wanted to go and I still want to go. And particularly as I read what goes on there during COVID and have it, but I mean, the discussion that we had with that group so deepened my understanding. When people were saying, you know, we can't worry about food because we don't have, I mean, about healthcare because we don't have food, or we can't get to see a doctor because the doctor, I don't have insurance, and the doctor says I need $60 before you can even walk through the door. So we don't walk through the door. Or Tammy talking about having a young mother who had a serious heart problem, who did not get the medication that she needed for months because she literally had to buy food for her children. I mean, she was risking her life. I mean, those kinds of things are not things that we can know or assume or think about without hearing them from the people who are experiencing them. And that's why it's to me, it is so profound to not go in with a set of assumptions, or not go in and say, this is how we're going to do things, but to say, you know, what is important to you? What matters to you? What are the issues that make a difference?
And how can we help?
That's exactly right. We do have a couple of questions coming in, so let's transition to the Q&A portion. As a reminder, just please type in your questions to the chat. I'll be sure to address them with the speakers. The first question, I'd like to pursue a community research initiative, but I'm not sure where to start. What are the first steps, or what is the best place to start?
What?
So first I would ask why? Why do you want to do it? What do you want to learn? What do you start asking some of the really, really basic questions? And who do you want to partner with? And what impact do you think it will have on the community? And, you know, we will definitely share these slides with you. We also will share some of the findings that we did from this project, as well as the 2 blog posts we did. But I would start with, what impact are you trying to achieve, and why are you trying to achieve that impact, and how is it going to help improve access to equitable care, or access or equitable outcomes for the people in the community you want to work with?
Yeah, I think it's also good that it's something that's close to you. I mean, you don't want to try something that's completely outside of your experience. It should kind of come from you. I mean, a couple of our volunteers, they may even be on this session. They had experience with food insecurity, or with not being able to find insurance programs, not knowing how to do that. As a result, those are the kinds of programs, even though they weren't exactly on target with what they had experienced, those are things that they learned from their own experience, were things that people were struggling with, or needed help with. I just did an interview this week with Mary Stabile, who may also be on this call, I don't know, who talked about how, from her experience, she wanted to start a little foundation that wasn't going to give money. It was going to give people things they needed, whether it was food or even something for their pets, because sometimes pets can be a really big issue. You know, you don't have any money, you can't feed your dog, and your dog is really important to you. So just sort of thinking how you can make that kind of synapse, that connection between your experience and what you know or perceive or are here as a community need, and also what's possible. You know, if you bite off too big a chunk, and it can get frustrating pretty fast. You want to do something that's doable, or at least start with something that's really kind of, you can define it, and you feel like you can make some progress and make it happen.
And I will just add that Jamie, Chris, and I are resources for you if you wanted to talk about a specific project and get some more background information. I know we ran through this very quickly, so we are there, and we are resources for you.
Great. Our next question, are there particular projects that NPAF is interested in pursuing in the community?
Well, Gwen, do you want to?
Yeah, so we are actually Chris and Jamie and I and a number of other people are just about to we have been working on an ongoing initiative around trust and equity to ensure that people get the care that they deserve. And, you know, a lot of the things that we've been talking about throughout the course of this patient Congress. So we are actually, as part of that, we will be doing a series of workshops in communities. We'll be doing a special issue of the Journal of the National Medical Association. We will be doing some workshops, active listening workshops for healthcare providers, physicians, nurses, PAs, community health workers. So we have a very ambitious program of things that we want to do, and we want to measure what that means, because people talk very much about trust and trustworthiness. This is one of my when you can probably visualize me standing on my soapbox, but you know, a lot of times what we talk about is why patients should trust their providers and trust their healthcare providers and trust the system. But we don't often talk about why the system doesn't trust the patients. So when we think about something like what happened in Mississippi with people having these incredible barriers and burdens to access, some of that is about the healthcare system not trusting the patients and the healthcare system not seeing what patients needed in order to access care. When I think about why I started in advocacy, it was because my doctor didn't believe me that something was seriously wrong with me. And it turned out I had cancer, and I trusted him, but he didn't trust me. To what we talked about in the first day and Shanta talked about in terms of the social determinants of health, social risk, and social needs, and how those impact each other, and how we can look at how we have to kind of simultaneously look at meeting people's social needs based on their social risks, but also work towards dismantling the structural racism and social determinants of health that stand in the way of people getting access to care. So that is that is just a very small introduction to some of the projects, some of the things that we're doing. But one of the things that excites us very much is that we are also going to try to evaluate and do equity evaluation around what we're doing in the community and what impact it's making and what changes it's making. And the community, thinking the community as a larger community, including healthcare providers who are Black, Indigenous, or people of color, so that there are also huge barriers there. So that is an ongoing initiative around trust and building trustworthiness, and looking at it through the lens of all of the different stakeholders. And through that, we will also continue to do these community outreach activities and a lot of the workshops that Chris has been doing on active listening and storytelling.
I would also add that the theme of this particular patient Congress is healthcare navigation. And one thing that we hear a lot, I mean, all the time, is that there's a real need for more peer navigation, for more patients and caregivers who are willing to help navigate. In fact, I just interviewed Meg Gaines, who some of you may know. She's been involved for many, many years. She started her life as an advocate when she was diagnosed at quite a young age with advanced ovarian cancer, which she survived. And I asked her, how did you get started as an advocate? And she said, well, her doctor asked her to talk to another woman who was really struggling with her diagnosis. And at the end of the interview, or end of the time they spent together, the woman said, you know, the insurance company is denying my hospital admission. They say I'm only going to get 2 days, and the doctor says I have to be in for at least 5. And Meg said, as only Meg can say, give me that letter. And she said that was the point at which she decided that she was going to stop just advocating for herself and was going to help other people. So there is that kind of connection between I'm a good self-advocates who now I want to move forward and help other people. And that there's a real role for patients who help others navigate the system, who, because they've been through it, they've lived that experience. They now know, how you talk to your insurance company when you need 5 days in the hospital and they're saying you only get 2, or they know what resources you can go to. They know better how to pick an insurance plan. They know better where to find resources like food and those kinds of things. So that's an area that I think a lot of people can feel very comfortable with, like taking their own lived experiences and helping become advocates for others or helping others navigate the system. Because this is really what we're talking about a lot over these 3 days, is finding better ways to navigate the system.
That's great. We have 2 additional questions and we're coming up on time. A question from Wanda. I was struck by the example of the interaction between the physician and patient in Chicago. What type of training or background did the physician have? Was there any follow-up with the physician and patient on what their relationship was like that encouraged that exchange?
So that's a really interesting question. And I think that's part of what we're going to try to explore when we do our Trust and Equity Initiative, because this was what was reported by the patient in our workshop, and the physician wasn't in the workshop. We know that there are, and so I don't know what that follow-up is, and it's a really important question. And I think that's a really important question that we can put in the kind of list of things that we want to consider as we measure impact and as we measure equity impact. Chris, you want to add?
I just want to say I included that particular quote because I wanted to illustrate that not all the interactions between physicians and their patients are bad or negative or unsatisfying. There are a lot of physicians and not just physicians, but nurse practitioners and social workers and other people who are involved in the healthcare team who really do care about these things. Sometimes patients have to be a little more proactive about bringing up the issues that they care about. And I think, Kevin, just last fall, I did a 5-part session on active listening with medical students from Temple University here in Philadelphia. They're young, they're idealistic. They signed up for an active listening course. They were extremely interested in having these kinds of conversations with patients and in knowing what mattered to patients and in addressing those things. So I think it's creating that kind of safe space where people can have these discussions and doing better training for doctors, but maybe better training for patients too.
All right. And our last question comes from Jessica. As a volunteer, what is the best way to collect data? Should I try collecting data from people I know, or is there access to some databases through NPAF, PAF?
Well, I think it depends on what you're, hi, Jessica. I think it depends on what you're looking to collect data about. So there's certainly the project that Rebecca Angove is leading in terms of the kind of patient cohort and advocacy cohort to collect data. There's also ways that you can just collect very simple demographic data from people. We did not do this. This was a research project, but we did this as a sort of advocacy research project. So we recorded, we analyzed, we looked at things, but we didn't use kind of rigorous data methods in this specific project. So again, we are here as resources for you. We can tell you about the different ways that we've been working with different communities and how we've developed the data. And also, I hope that next Patient Congress will be able to report back to you a little bit about what we've learned from the equity and the Trust and Equity project, because one of the things we're working with a group, Mathematica, which is a great research group, on learning how to collect this data and how to create these impacts. And one of the outcomes of that project is that we'll have models for collecting data and for evaluating impact that we will share with everybody, that we're not doing these just for NPAF or PAF, we're doing these for our community, which is our larger community of you and everyone that we work with now and will work with in the future. So we will share that with you and look forward to your feedback on all of these projects.
And I know we're out of time, but I just want to chime in very quickly. Jessica, there's lots of kinds of data. There's quantitative data, which is, counting things and measuring things. There's also qualitative data, which is getting people's responses and reactions. And you can do that much more simply in many ways. You can just ask people what they think or what mattered to them or what changed for them. And I also know, Jessica, that you are one person who has used your lived experience to create some pretty effective community programs. So I think it's great that you're interested in moving to the data phase of things. And I know we're out of time.
Yes, we are. But thank you both for this robust and interactive discussion. And thank you to all of the participants for your questions. We are moving into a 15-minute, 14-minute break. Reconvene at 1:45. You will have the option between two sessions. The first on public policy update, what matters to patients, and the second convening a COVID-19 learning community focused group discussion. Refer to your agendas for the links to each of those respective sessions, and we will see you back later this afternoon. Thanks, guys.
Thank you, Jamie. Thank you, Chris. Thank you, everyone.
Hello, thank you all so much for joining us for session 3A. We are going to be having two discussions, or one primary discussion. But we're going to share a public policy update and discuss what matters to patients now. This conversation will be directed by Melissa Williams and Nicole Braccio from NPAF. And just to go over some quick housekeeping for you all before we begin this session. First, please submit any questions you may have in the Q&A box in the control panel on the bottom of your screen. There will be closed captions available as well for this session. And at the end of the session, materials will be emailed to you. So you'll have access to the PowerPoint presentation. And as the video or the recording becomes available, you also will have access to that. And if you are on social media, please use the hashtag #HealthNeedsNav to join in the online conversation as well and share certain things that you may be learning in this session. And of course, as always, we would love to know where everyone is joining us from. So drop in the chat which state you're joining us from. And if you're affiliated with any particular organization, please feel free to drop that in the chat as well. And so right now I will turn over this conversation to Melissa.
Thank you so much, Mary. Hello, everyone, and welcome. Thank you so much for being here, a part of Patient Congress. It's always tough to be doing meetings virtually. I know we've been doing them for 18 months now, but it's not quite the same as being all in the same room together. But we thank you for participating and for your feedback. Happy to get started here with our session, Public Policy Update, What Matters to Patients Now. And before Nicole and I dive into, what is it that is really top of mind for patients and caregivers today, wanted to just take a moment and reflect on the year that we've had. So a year ago, this time, we had COVID cases surging. We were in the midst of a recession, financial hardship. We were just like the economy was just starting to open up. People were beginning to go back to work. There were no vaccines authorized yet. And we were approaching the 2020 presidential election. It's been a tough year. It really has been. And I think, if anything, this pandemic has just really underscored or exposed many shortcomings in our country, including many of which that are in our healthcare system. And I think this slide here really encapsulates that, what people have been experiencing, especially those limited resource groups that have been hit the hardest by the pandemic. In the first bullet point here, a study that was done by researchers at the University of Michigan, they found that there's been high mortality seen due to COVID in Black adults, Hispanic adults, people without insurance, people living at or below the poverty line, people in occupations without work from home options, including those workers who are in maintenance and repair industries or transportation workers. And we know that, it's not just people of color or limited resource populations that are impacted by the pandemic. We also know that patients and caregivers have been hit hard as well. In fact, 41%, according to the CDC, of US adults have delayed care due to COVID. And most prevalent here are, those groups that have avoided urgent or emergency care were higher among unpaid caregivers for adults, people with underlying medical conditions, again, Black adults, Hispanic adults, young adults, and people with disabilities. I just want to emphasize again, just how tough a year it has been. And we know that if you're, we've all been juggling a lot. We know if you're particularly a woman or a person of color, burnout is real. And if you're a patient and a caregiver on top of that, you're already toast. This is a book by Kate Washington that's been on my reading list. And I just thought the title is just so fitting for what many of us have experienced over this past year. And I don't mean to paint such a grim picture here, but I did want to acknowledge just how tough it's been. And our discussion today really isn't going to focus so much on, how things have just upset us, but by what we've seen happen in our country, but rather we want to focus on the things that are giving us hope. And not to be, corny right now, but honestly, the hope that we get is from a lot of you participating here. You all are what fuel the work that we are doing. So we're happy to go over these things here today. We're going to talk about some of the policy changes that are happening now and who they impact. And we'll also go into some detail about the public policies that we stand for and how we advocate, and some of the community campaigns and actions that you can take as what you can do to further our work and our mission in your communities. So at this time, I'm going to turn it over to my colleague and teammate, Nicole Braccio. Go ahead and take it away.
Thank you, Melissa. Hello, everyone. Nicole Braccio here. I can't see many of you, but I'm just imagining us being in a room together, having these conversations as we did 2 years ago. So I think, we're going to start off with a polling question, just to kind of set the stage here a little bit. Melissa did a great job of sort of painting what we've been, stressing over around just the state of, healthcare in this country, but really focusing, I think both of us are sort of optimists at heart, and we really wanted to focus on what has been going well, as well as what, some of the examples are of how federal relief and investment in the things that we care about are going through the social safety net, health insurance, and costs of care. So the first question, and some food for thought, we'll have a couple more of these questions throughout the presentation. But the first question is, has your health insurance or financial situation changed at all during the pandemic? So you'll, if you'd like, you can answer the polling question. I'll give you a couple seconds for that, because there has certainly been some change that we've been monitoring over the past year and a half, and really has been pretty significant for everyone in your individual lives, but we do have some good news to share, and some hopeful notes moving forward. So I'll leave that there for just a moment. And this can be, when we ask about if your insurance has changed, was it potentially a job loss that led to, insurance loss? Did you change from one insurance type to another? So did you leave your employer insurance and go to a different type of health plan? Even within, the way that you get your health insurance, have you changed plans from last year's open enrollment period? And in terms of financial situation, just in general, how has that changed for you? We know, the recession has certainly caused a lot of financial strain, and we know that financial distress is a concern for many, as highlighted in some of the presentations yesterday. So I think people are still answering, but looks like 63% of people say that they have not experienced a change. So that's great. It's always reassuring when things are stable and you're not worrying about your health insurance or your financial situation. So I'm glad to see that number so high. But unfortunately, in other places in the country, that number, might not be so high. So it really just depends on where we're coming from. So with acknowledging that, I will share some of the good news that we've seen. And this is all based on some recent census data that has come out accounting for the year of 2020. But the good news is that health insurance has actually held steady for 2020. And the percentage of people who are uninsured is roughly 8.6%, which is 28 million people. So it's still, a significant number. However, the other good news is that the poverty level actually has decreased slightly from between 2019 and 2020. And Melissa, I'm not sure if the slides are advancing on your end, but there we go. Thank you. So those are two bits of good news, but I will caveat that to say, clearly 28 million people without insurance is still a very high number. But just looking at the bright side here in that theme, with all of the pandemic related recession and job loss, what was interesting and sort of reassuring is that for many people who lost insurance because of losing their job, there was a major uptick in the amount of people who kind of shifted over into Medicaid as well as marketplace plans. So, those are components of the safety net. I mean, we really do have our social safety net to thank, as well as all of the efforts at the federal level to make health insurance more accessible, as well as to increase some of the financial assistance that you can be eligible for on the marketplace specifically. With respect to Medicaid, there were policies early on in 2020 that basically made it really hard or really easy for you to maintain Medicaid coverage if you're eligible, and including if you're newly eligible. And then with the marketplace coverage, not only was there a special enrollment period for COVID, so you can access a health insurance plan on the marketplace for any reason. Additionally, some more financial help became available after another stimulus package passed earlier in 2021, and that was the American Rescue Plan. But it's really a combination of all of the stimulus packages going back to early 2020. If you remember the Families First Act, the CARES Act, and then in 2021, the American Rescue Plan. So, other components of this as well include the expanded unemployment benefits that, up until recently, just a few months ago, were still intact. And some states can also may offer additional benefits, but at the federal level, that was a huge help for many. Other things like nutrition support, and then of course the stimulus checks that many Americans received was a huge part of the financial relief made possible by federal policies. And just a quick note on the poverty level decrease. I don't want to overlook the fact that clearly with the recession, and we recognize that many families have struggled and still struggle to make ends meet. So, a slight decrease in this measure still translates to many millions of people needing help. But the sort of one positive note on this side is that even though household incomes may have decreased and financial strain, is still occurring, the measure called the supplemental poverty measure, which is a more accurate reflection of what poverty looks like in this country, that was actually decreased for the first time in a very long time from year to year. So again, this is largely due to the significant financial and social support through the stimulus packages. And so next we're going to look at public policy happening now and sort of where do we go from here? Because a lot of these provisions were in effect, from last year. But thinking about what's happening right now, you may have heard in the news for the past several months, there is a major economic plan called the Build Back Better. And it's moving through Congress through a process known as budget reconciliation. So just to give you a couple of points on what this plan would do, this is a proposal, it's customary for this type of bill, especially in the process that it's following through reconciliation in the Senate, it feels like it's very up in the air because there are a ton of negotiations happening. Congressional leadership is working through the details, mainly around the price tag for this major plan. However, we are encouraged by some of the provisions inside that will really strengthen the safety net in the way that we've seen some of the stimulus packages strengthen the safety net. So for example, one of the provisions would be closing the Medicaid coverage gap. So, many people here may be familiar with that, in that, there are a number of states who have not yet expanded their Medicaid programs. And so people who are making, sort of in the middle, right? They're making too much to afford Medicaid in their state, or it's not accessible to them, or they're making, they're not making enough to really be able to afford the other types of insurance that's available, like marketplace coverage. So this plan would take steps to close that. gap. The other piece that I started to mention earlier around this financial assistance in the marketplace plans, the American Rescue Plan, boosted not only the generosity of the financial assistance, and this is through what's known as premium tax credits. So if you're if you're eligible, you would receive sort of a break on the premium. So your premium cost for your insurance plan would be lower. So the American Rescue Plan boosted that and made it available to more people. And then the Build Back Better plan here would make that permanent if this provision were to be passed as part of that. So we really like to see that because one of the things that we hear often is, insurance is too expensive. Even if you are eligible for a marketplace plan, it might not always be affordable when you compare or add in other costs like living expenses and things like that. And then the other two provisions that we're encouraged by is an improved paid family leave plan, as well as improved home and community-based services. So these are both healthcare priorities for NPIF and for many in the patient community, because paid family leave, that is a huge help for caregivers, as well as home and community-based services, which is a Medicaid benefit, would help more people be able to receive care in their homes through long-term services and supports, which we know is very costly and often we don't always think about until it's too late. And so the other piece that we wanted to highlight here for you is, who would the Build Back Better plan help? So when you put it in terms of people, we're looking at people with complex and chronic conditions, caregivers and parents, people who don't have health insurance, people with limited resources, as well as people who need care in their homes. And I include this picture of all of us from Patient Congress a couple of years ago, because really this plan and just the concept behind each of the provisions would really help all of us. We're all here because we're passionate about making healthcare more equitably accessible and affordable. And a lot of the concepts behind this bill would do just that. And I'd also like to emphasize here that this is, we're trying, I think, as a patient community, some of the provisions here would really help those people who are sort of least likely to be helped and who are least likely to be represented in data, and really just their voice being represented in the healthcare reform debate and discussion. So again, I wish I had a magic ball to tell you what this plan will end up looking like and when it will pass, and what that will look like. But unfortunately, no one knows where it stands right now. But that is, sort of customary for this type of process. And NPAF, as well as others in the patient advocacy community, have been communicating our priorities to Congress to try and ensure that these healthcare priorities are not overlooked, because this Build Back Better plan also has environmental provisions as well as other infrastructure pieces that end up being competing priorities for Congress. But we know that the healthcare priorities are as important to you as they are to us. So we will continue to keep pushing for that. Next, we have another food for thought question. So we're going to dig a little bit more into insurance coverage. So just be thinking about this as we go through the next few slides. If you have insurance, are you satisfied with it? And if you don't have insurance, what is your biggest concern with that? We hear a lot about the affordability challenges, but also, what are some other things that may make you satisfied or dissatisfied with your insurance plan? I will hold my answers, but just be thinking about that in your heads as well. And then the public policy happening now piece. So alluded earlier to the fact that there was a special enrollment period for marketplace coverage. So if you've been a volunteer with NPAF or volunteered in healthcare before, you probably know that open enrollment is coming. This is an annual period every year. And we focus our Get Covered campaign, which is coming up later in the year, on spreading the word about open enrollment. One of the policy changes that have happened through the administration, so this is through a regulation, is that the open enrollment period now, if you remember from a couple years back, it was shrunk to only 45 days. But now through regulation, the open enrollment period for the marketplace is extended through January 15th. So previously it was December 15th. So this is great. We're, thrilled that people will now have more time to make changes to their plan. So along with this longer open enrollment window, remember that the boosted financial assistance for premiums will be effective through this next open enrollment plan year. So if you are soon looking to buy a health plan on the marketplace for coverage for the year of 2022, you will be eligible for this additional financial assistance if you qualify. I think the other piece is that there are actually now more navigators that will be available because additional funding was allotted for the federal navigator program. And we talk all of the time about navigators. This is one example of a navigator in the insurance space, but happy to see this happening. And then note that when we come to you, in your inbox in a few months around open enrollment, we will be sharing with you our new resource, our updated resource for choosing a health plan, because open enrollment is the time to think about making changes to your healthcare in general, and because that can affect what health plan you choose. And just note that it's always important to your well-being that you feel confident in the care that you're receiving. And with that, we have one more update and food for thought question. So here's the next one is about surprise bills. So most of us, if not all of us, have been caught off guard by a medical bill. But if you have, and if you've known about these costs sooner, would you have done anything different? So that's the question we're asking. Would you have done anything different if you knew about this medical bill before it was a surprise? The reason why we ask is because one of the public policies that is happening now through this year that will be effective in January is surprise medical billing protections. So unexpected costs of care, like surprise medical bills, can lead to this financial distress that we know is a concern. And as you also know, policy change can take time, but in this case, protections for surprise medical bills is happening before our eyes. So I'll just share briefly that a bill was passed late last year, but the regulations are happening now to implement this bill, the No Surprises Act, which is now law, that really takes important steps to hold patients harmless from these surprise medical bills. So it ensures that you will not pay more for care if you receive out-of-network care without your knowledge or consent. This also, there is a provision around not being responsible for out-of-network care if it's an emergency. And it also makes clear your options and your financial responsibilities. So one thing to look out for, starting in January 2022, the way this will look, the way you'll see it when you get care, is that there will be a written notice ahead of a planned procedure from hospitals and facilities about the out-of-network care and cost estimates. So if you do want to receive out-of-network care, like for example, if you want to see a specific specialist and you know that they're out of network, but you don't care, you want to see this person, this doctor, then you will be asked to sign a form to waive your rights to surprise medical billing protections. I think the other piece to this, and Melissa, I think the slide might be stuck. There we go. Yes, so as part of the regulations, these written notices are required, and you will have the chance to sign a form to waive your rights if you do want to move forward with out-of-network care. But the point here is that you will be given advance notice, and so, you know, be prepared for that. If you see this, you know, be thinking about what would you change or what would you do differently? Would you try and find a different provider if you knew only an out-of-network provider could see you? You know, because that can change the calculus, and it can also change just logistics of when and where you're getting care. And then finally, on the next slide, we will, I'll just preface that Melissa and our team have worked on a wonderful new resource to be thinking about some of these conversations, because, you know, these regulations are a great step forward. However, we know that written forms alone are not always enough, and especially for people with visual or hearing impairments, limited English proficiency, if you struggle with health literacy, or, you know, have other factors going on that can make it difficult to, you know, receive these forms. Really, we need to be asking about, well, expecting and asking for conversations with our care team, you know, whether it's the doctor or the hospital staff, about course costs and affordability. Really, this is the best thing we as individuals and patients and caregivers can do to avoid and prevent these unexpected costs. But also we have the backup of these new regulations so that we're protected from high bills when we had no knowledge of receiving out-of-network care. And I think with that, I just wanted to pivot quickly to some of our policy priorities, and you may have seen some of this slide or this graphic before. But you know, I hope I made it clear where MPAF stands in all of this. But here are sort of the 4 key areas where MPAF, with your help, can influence policy at all levels. We think, and we're thinking about this at the health system, local level, state level, and national level. And we strive to approach each of these issues with a health equity lens, thinking about who will these policies affect and how will they assist those who have been traditionally overlooked. So of course, you know, I'll just breeze over this because you'll see it in the slides, but our one of our top priorities has been navigating people to safety net programs to address their needs, whatever those may be, financial and social, is a huge part of that bucket. Person-centered services that match what people say they want, communication and coordination that positions people at the center of care planning, and finally, but last but not least, ensuring that all people have equitable access to coverage and care. I think that is sort of where we hang our hat in terms of the priorities that really transcends all of the different campaigns that we're launching this year. And I'll pass it off to Melissa, who will share a little bit more about that. And with that, the last thing I'll just say is that in terms of this health equity lens, we are encouraged that both Congress and the administration appear to be paying much closer attention to health inequities. So this is, you know, a good opportunity for people like you who are very well engaged in your communities to bring all of the experiences that you and your community has to this process with us, or you know, independently, because this is certainly a priority for federal lawmakers. So Melissa will share more about other things you can do to get involved.
Thank you, Nicole. And before I talk about those different opportunities, I wanted to just take a moment to acknowledge what a critical time we're in right now. I think what you've underscored, Nicole, and what I set up initially with all of the things that are happening right now, we're at a critical point where we can come together and say exactly to our policymakers, whether they are on Capitol Hill, whether they are in our hospitals or health systems or our communities, this is what's impacting patients right now. This is how we can be a part and improve our healthcare system. And I wanted to just underscore that because, when we think about our agenda here at our National Patient Advocate Foundation, we talk about just how focused we are on person-centered care. And that is also our approach to advocacy. It's person-centered, it's community-driven, and we rely on our volunteers to help build that demand in their communities so that our policymakers can take notice of, what are these things that really matter to patient and how can we meet those needs? We think that is pivotal to advancing our needs navigation agenda. And we think it's pivotal to addressing the health equity deficiencies we see in our healthcare system. So I started off the presentation looking back at the year that we've had and wanting to acknowledge that, yes, it's still incredibly tough. But I also just want to show just how proud of some of the work that we've done here at National Patient Advocate Foundation. Many of you who have participated in our campaigns have seen that we've outlined this year of different opportunities for you all to get involved in our initiatives and bring our message to your communities. And we're so excited that that you all are a part of it, and we're just thrilled to continue this this plan for our campaigns throughout the years to come. And I just want to just underscore that it really is you all who helps just brings that hope to what we feel. And I feel like I'm sounding a little emotional, but maybe I am because it's been such a tough year. And it's when Mary and I and Nicole, when we connect with you all, our volunteers, about what it is that you're doing in your community, it's what makes us, it's what fuels us. It makes me less cynical for sure. And I think it is just incredibly moving to see that despite everything that this year has thrown at us, what you all are doing is, you know what, you're not angry, you're not just throwing your hands in the air. Maybe you're doing that too, but you're also channeling it to how can we make this better? How can we make our healthcare system better? And I just wanted to give a shout out to all our volunteers who have shared their story in some way, whether it's through a blog or sending us videos or physically going out to communities and sharing our resources. We salute you, and we encourage, if you are new to NPAF, if this is your first time tuning in, we want to make sure that if you have a community here among our volunteer network, and we encourage you to be a part of that and sign up if you haven't already on our website. I'm being mindful of time, so I want to make sure that we answer and acknowledge a lot of the comments and questions that are coming in through the chat. So Mary, I'll turn it over to you to see what kind of conversations are happening.
Thank you. So one of the first questions we have is financial help from the stimulus bills still available now?
So the short answer is unfortunately no. Most of the federal relief has lapsed. However, depending on where you live, there might still be some assistance available through your state. I know some states are still offering expanded unemployment benefits, as well as eviction moratoriums, and additionally, nutrition assistance might still be boosted in some states through their own networks. But the other good well, the other piece that is still available is some of the tax credits. So when you, if you're eligible for any of the tax credits that came out of the stimulus bills, so most recently it was the child tax credit, the earned income tax credit, and the child and dependent care tax credit, those, could provide a substantial amount back to you, but you wouldn't receive that until you file your taxes for next year. So that's more of a longer term relief that is coming. But for the most part, the only thing that still is in effect around financial assistance is the tax credits for the marketplace insurance plans, and that's throughout the 2022 plan year. A great question. And I wish, if anything changes, we will certainly let you know, but for now, that's where we stand.
Thank you. And we have another question coming in. What conversations patients and their advocates need to have with insurers? One of the comments after was that she expressed her concern about whether or not insurers would be motivated to improve and maintain networks offered in their plans.
So I think this sounds like it's a question about like provider networks and who's included potentially as part of that surprise medical billing conversation. Yeah, I think it's challenging because there are hundreds and thousands of different plans. And, if we're talking about Medicare, that's sort of one piece. And then Medicare Advantage is administered through private plans, with each of them having their own network, usually local. But when it comes to sort of commercial plans, if you have employer-sponsored insurance, it's almost, there are so many thousands of plans, but it is absolutely worth it to, raise awareness about the concerns or the questions you may have about who's in your network, especially if you see a doctor or specialist that you really want to keep seeing. And, there could be a chance that at some point that provider may no longer be in your network, but it's certainly, always helpful to initiate those conversations, because I think without that demand, without, hearing from people about what they want, it's harder to continue to make the case for, keeping things the way they are. So encourage that whenever you can.
Thank you. Another question that we received in the chat: what financial assistance are available to pay premiums for people who may not necessarily be eligible for government offered subsidies?
Right. So here's a great plug for some of our Patient Advocate Foundation financial assistance, as well as I think this is a really great place to actually contact a navigator to see what might be available in your local area. To my knowledge, there's there's no government funded premium assistance for non-government programs, right? But there might be ways through talking to a social worker, community health worker, some type of navigator to see what might be available in your area, because a lot of this is, county specific. And, one place you can go to for navigation if you have a complex or chronic condition would be, of course, the Patient Advocate Foundation. But, I think this is where that navigation really comes into play, because we don't always know, the go-to place for some of this assistance, but navigators, would have a much better idea of that.
And let's see, I have questions coming in that I can see here. There's a question from Deborah who asks, I think when we were talking about surprise bills, Nicole, does that mean non-network providers can surprise bill?
non-network providers. So, well, there are some exceptions depending on what type of specialist it is, but in general, if a provider is out of network, but the patient is receiving care in an in-network facility, the out-of-network, the patient will not receive an out-of-network bill unless they knew about it, right? So that's what the consent form is about. So if a person, goes for a planned procedure, and again, emergency situations are sort of exempt from this. Surprise medical billing protections will always stand if it's an emergency, especially if you're, not in a position to make a decision. But if you have a planned procedure and the hospital tells you there's only an out-of-network provider that will be able to treat you, you can then decide, okay, do I want to move forward with the procedure knowing that I will, potentially pay a higher bill, or you can decline and look elsewhere or reschedule to a time when you will see an in-network provider. So generally, for planned procedures, no, the out-of-network provider cannot bill unless you give them permission to.
That's exactly right. And there is just one last question. I know we're coming up at time that came in, but I think it's an important one to ask out loud. Is there an income eligibility threshold to qualify for services or financial assistance at Patient Advocate Foundation?
Yeah, that's a good question. I don't believe so, right?
There's there
isn't. Being on the NPIF side, but it should be just the having a confirmed diagnosis of some sort of condition, of which there are like many hundreds of conditions among the patients served at PAF, but no income threshold.
That is correct. All right, so I think that wraps up Nicole and my session here. Just a plug, if you are new to us, to please sign up to volunteer at npaf.org. We also include our emails here, so if you have any questions at all, you are certainly welcome to send them our way and we'll be happy to answer them. Coming up next is our fourth session and last session of the day, collecting evidence to support needs navigation. And we will be joined by a panel of wonderful researchers across the country. And we'll get started in just a bit. Thank you.
Hello and welcome back from your breakout sessions. I am Ashley Freeman and I will be your host for this last session titled Collecting Evidence to Support Needs Navigation. So before I turn it over to our panel of speakers, I would like to share some reminders with you all. I know if you've been with us all day, you probably have heard them multiple times, but if you're just joining us, it's good to know. So if you have any questions during the presentation, We ask that you enter them below in the Q&A box at the bottom, and we will try to address as many questions as we can get to. Also, closed captions are available for today's session, so you can also enable those at the bottom of the control panel. In addition to that, all of the resources will be emailed to you later today. And if you are experiencing any technical difficulties at all, please email npaf-events@npaf.org, and a staff member will make sure to assist you. And also, if you're new here, please let us know in the chat where you're joining from and what organization you are affiliated with. And in addition to that, we want to hear you on social media. If you're tweeting, if you're on Instagram, please use our hashtag #HealthNeedsNav, and that will be at the bottom of our screens at all times. And so now I will pass it on to my colleague, Kate Gallagher, who is our VP of Health Services Research.
Ashley, thank you so much. I'm so excited to be here today. We've got a great group of panelists set up to speak with you about how can we collect data to support social needs navigation. First of all, I'd like to go ahead and give everybody just a quick introduction in no order whatsoever. So Dr. Gallare Sadi is an assistant professor of neuroradiology at Emory University School of Medicine and is a health services researcher. Her primary research interests have focused on cost of care discussions, enhancing informed decision-making, mitigating financial hardship, decreasing healthcare utilization, and improving health outcomes. Next, we'll be hearing from Courtney Williams, who is a health services researcher and cancer prevention postdoctoral fellow in the National Cancer Institute's Healthcare Delivery Research Program. Courtney has a background in health policy, economics, and decision science, and she's passionate about decreasing costs and increasing the quality of patient-centered cancer care delivery. Donald Rosenstein is a professor of psychiatry and medicine at the University of North Carolina, Chapel Hill, where he is the director of the Comprehensive Cancer Support Program and division head of general adult psychiatry. And Dr. Catherine Courtwright is an assistant professor of medicine at the University of Pennsylvania, where she attends in the medical intensive care unit and is on the palliative care consultative services. Her research aims to improve the effectiveness, efficiency, and equity of palliative care delivery among seriously ill patients in the hospital by leveraging insights and methodology from the fields of data science, behavioral economics, and implementation science. So to kick off today's session, I would like each of you, if you would please provide the audience just a brief overview of your research experience or your experience working with the team at PAF. And let's go ahead and start with Gallare.
Absolutely. And thanks so much, Kate, again for invitation. I'm happy to be here. So as Kate mentioned, I'm a neuroradiologist at Emory University, and my research on financial hardship started around 4 or 5 years ago, when every time I was opening a patient's chart, I was seeing that the patient skipped an imaging, and then looking at what the reason for that is. Sometimes you would see that the cost is the reason. And that's how I started looking at cancer patients and also multiple sclerosis patients' financial hardship. And we started some projects with PAF as sort of a solution to how to improve this financial hardship. Our first project with PAF was focusing on brain cancer patients, population at high risk for financial hardship, just because they are on very expensive medication. They have very high mortality, which cause this cost of care be accumulated during that first or second year of their cancer diagnosis. And also they become very fast cognitively impaired and lose their job and income. And so we work with PAF, offering them financial navigation, which was on a regular basis with them and their family, and to see how the impact of that is. We also work with PAF on another project in metastatic breast cancer patients to improve improve these patients' adherence to CDK4/6 inhibitors such as Ibrance. And we were offering these patients an mHealth and seeing what the reasons for their non-adherence is, and cost as one of those reasons. We were referring them to the PAF. And as follow-up of those studies, we have submitted several larger grants in collaboration with PAF, and we're looking forward to continuing those collaboration with PAF.
Wonderful. Thank you so much, Gelare. I'm going to actually jump to Don Rosenstein, since your project is kind of a similar structure to Gelare's. Do you want to tell us a little bit about it? Oh, maybe.
I'm going to do the best I can. Can you hear me, Kate?
We can, and we know being in clinic is tough.
Yeah, and for whatever reasons, my computer is not cooperating. Hello, everyone. My name is Don Rosenstein. As you heard, I'm a psychiatrist and I work at the University of North Carolina. And together with Stephanie Wheeler in the School of Public Health, we have a project that essentially addresses the problem of financial toxicity in rural cancer centers. And this was a project that grew from a small pilot that we did right here in Chapel Hill at our medical center, and now are extending to over 700 patients throughout North Carolina in rural cancer centers. And rurality is defined differently by the federal government, and so we could talk some about that later. But the short version of kind of our work is to identify people through systematic screening in cancer centers who are at high risk for financial toxicity, and then to have a real hands-on approach. And our relationship with PAF is a really interesting one, because essentially what we are trying our best to do is to have local hands-on navigation to help people identify what kinds of programs they qualify for, and to help them, in a sense, become more financially literate and effective. And then partnering with PAF for when we have the local navigators have exhausted their resources. And so it's been a creative process of trying to figure out kind of where the local navigators' work ends off, and when we kind of push a call a friend button to PAF to help us identify national resources. And so we are about to begin recruitment of these 700 and some odd patients. So I can't tell you how it's working yet, but can tell you what the plan is. There's time. Is that what you needed, Kate?
Perfect. Thank you so much, Don. And we're actually going to switch gears just a little bit, because we do partner with groups to do things other than just intervention research. And so I'm going to switch over to Dr. Courtney Williams and have her tell you a little bit about the work that she's done with a couple of different organizations that she's been active with here at PAF.
Yeah, thank you, Kate, and thank you, PAF, for allowing me and inviting me to serve on this panel. So my work with PAF started, I think, about 5 years ago in collaboration with my research team at the University of Alabama at Birmingham and Dr. Gabrielle Rock. We partner with PAF to first look at what types of safety net resources PAF, the patients served by PAF utilize, and specifically those utilized in individuals with cancer. So that research project was done using a nationwide sample of individuals served by PAF, which then led us into some other research questions about patient priorities during treatment decision-making. So in collaboration with the Breast Cancer Research Foundation of Alabama and PAF, we were able to survey about 220 breast cancer patients across the nation and really get into those questions about what patients really prioritize during that treatment decision-making process. So we asked them to really go through kind of a game where they traded off preferences about different attributes of treatment. So one treatment may have had more physical side effects associated with it, while the other may have been more expensive. And we asked them to prioritize. And after going through a couple of these choice-based games, basically, we could understand the utility of what patients really valued when making treatment decisions. We found that these patients really valued affordability of treatment and also being able to maintain their independence while receiving treatment. So that was just a really cool project that we were able to do with PAF and the individuals served by PAF. And currently we're looking at some outcomes for individuals during the COVID pandemic. So outcomes related to both medical and non-medical financial hardship that individuals served by PAF dealt with while undergoing the COVID pandemic.
Thank you so much, Courtney. Yeah, we've definitely been having a lot of fun with the survey design. And last but definitely not least, Dr. Kate Courtwright, do you want to tell us a little bit about your experience working with the team here at PAF?
Sure. Kate, can you hear me? I'm having a little unstable connection warning.
Yes, we can hear you.
Okay, great. It's okay if you can't see me, but so this is, thank you so much for inviting me. I feel like a newbie to PAF, which is exciting because I'm happy to hear about all the different ways one can engage. I feel like my engagement thus far is a little bit different. So I'm a pragmatic trialist in that I like to design our clinical trials for seriously ill hospitalized patients in sort of real world settings. So everything we do is embedded in routine workflow. All the data is collected, in the process of routine care. So we're not sort of directly recruiting and engaging patients. It's all clinician and healthcare targeted delivery interventions. And so when I reached out to actually NPAF, for really about a year now for 2 different proposals, it was really to make sure that if I'm going to call it real world research, I wanted to engage the real world in designing it. And it's really important to me that when we say we have patient-centered outcomes and patient-centered interventions and patient and caregiver, things that are important to them, and that their feedback is in every aspect of the design of the study, the outcomes measured, and frankly, helping interpret what we find. So we stood up a stakeholder group for both proposals, 2 pragmatic trials and 1 sort of qualitative interview study where several patients and caregivers committed a good number of years and their voices, and they basically are integrated into the study team. So it's fascinating and wonderful and has really changed and completely enhanced what I think our projects and proposals. And it will absolutely, although neither is started or done, I know it will help interpret with us interpretation of results ultimately.
Thank you so much, Kate. So as you can see, there are a lot of different ways that PAF can engage with providers, with researchers, and we have other data or patient populations that we can link. And so we've heard a little bit about these different projects, these different approaches. But what I really want to pose to the 4 of you is, what are the research questions above and beyond the work that you've already done that we need to ask to elevate the science and evidence behind needs navigation? And Don, let's go ahead and start with you this time.
Okay, thanks. I finally rebooted my computer and it was more friendly. So can you hear me okay? Good. So I was really interested to hear what Dr. Cartwright just said, because I think that pragmatic real world applications of all of this are really important. And I think those are huge gaps. And the analogy that I would start with is an analogy from kind of clinical medicine, and that's individualized therapeutics. That we know that there are certain medicines that are FDA approved for certain indications, for certain conditions, but getting to where you know exactly what medicine to use for which patient at what time is, I think, really critical. And so I think that is a next phase of all of this work, which is how can we be a little bit more precise? How can we kind of target the unique needs of people, since we know that, at least when it comes to financial distress, financial toxicity, there are multiple different components. There are behavioral aspects of it. There are psychological aspects of it. There are, not everybody is affected in the same way and at the same time. And so I would just identify that as a first important kind of next phase.
Great, thank you so much. I'm going to go to Courtney Williams next.
Sure. So going off the results of the work that we've done with PAF so far, I do think that one of the next steps we really need to understand is how to best incorporate patient preferences into clinical decision-making. Is that, using a navigator as a moderator? Is that collecting patient preferences via some sort of tool and incorporating those into the EMR? Is that understanding how to best facilitate these patient and provider communications? So really understanding how to best incorporate these patient preferences into clinical practice, both at treatment decision-making and then into survivorship, I think would be a great next step in this research.
Perfect, thank you so much. Gallery.
Yeah, so I'm echoing what other panelists already said, but also some other additional research ideas are like how we can tailor the financial navigation. When is the best time that we can approach the patient and offer financial navigation? I mean, there are a lot of discussions that maybe right at the diagnosis, you want to have a patient meet a financial navigator and talk about their finances before, and financially basically get prepared of what they're expecting in the next couple of months. But on the other hand, the patient is too overwhelmed with a new diagnosis, with new treatment. Is that the best time to have this discussion with the patient or not? The other thing is, what is the frequency of offering financial navigation? Should this be every 3 months, every 6 weeks? I mean, so there are a lot of trials like determining what is the best timing of giving this. And the other thing, like, do we want to offer financial navigation to every patient, or we want to screen patients, only those who are at risk, I mean, offering them financial navigation? So if so, we need to come up with screening tools that are actually helpful and like in identifying patients who are at risk for financial hardship. So I think there are a lot of things needs to be done in terms of tailoring this intervention. And on the other hand, we talk about financial navigation, but I think one other piece is also cost of care discussion. Like, in addition to offering financial navigation, we want to tell the patient how much your costs are for the treatment that we are offering, so that they can have they are better informed in terms of making that decision that whether they want to go to with that treatment or not. So I think these are some of the future research focus that we want to work on.
And Kate, from your perspective, what are some of the research questions that you think we should be asking?
Yeah, I think related to what Courtney was just sharing, and this reveals my biases around pragmatism and electronic health records being sort of the center, fortunately or unfortunately, of a lot of clinical care interactions. But I think we should use them to our advantage instead of allow them to continue to be just sort of billing and documentation tools. And one of the things I find is just an utter failure is actually the capture and documentation of actual social needs and psychosocial needs. So we sort of rely on these really basic social demographics that get entered by whomever, whenever, at one point in time when you enter a system. And then for the rest of your time in that system, that's sort of, all we know is a very binary gender or very classified race or ethnicity. And we know nothing else systematically about patients. And I don't think we have a patient-centered way of capturing this incredibly important information about their caregivers, about their social needs, financial needs, that both systematically and reliably is updated and allows us to do exactly what other panelists have said, which is sort of target high need patients and caregivers in an efficient, very high value way. And so I'm not sure it's so much a research question as it would be an incredible enhancement to research and clinical care if we sort of could, as a healthcare, system in the US, agree upon what are the actual social needs we should be capturing, and patients and caregivers should inform that.
So I like the trajectory of where your question has taken us, and I want you to stay on screen here because, what do you think then are some of the gaps, just in general gaps for actually describing how social needs navigation can actually fit in within the larger healthcare system and actually across this concept of a continuum of care, because we know care is not just one point in time. Care is something that is transitional. Sorry. Oh, Don, you want to jump in?
I couldn't tell if that, yeah, sure. So I think that it's really uneven, at least in the institutions I've worked at in that regard. There are some programs that do a great job. For example, in our place, the bone marrow transplant unit, the physicians and the nurses and the nurse practitioners, advanced practice providers see patients outpatient when they come into the hospital, and there's great continuity of care. Whereas in other parts of at least the cancer hospital and other parts of the medical center, you could drive a truck in the gap between those two things. So I think the continuity of care piece is terribly important. And I do think that there are, to a great extent, we do not take advantage of the information that is in our electronic medical records. I would agree completely with what was said earlier by Dr. Cartwright. So, for example, I see the kind of social determinants of health tab as being kind of an afterthought that sits literally on the front page and is typically not even fully filled out. And I don't see that as being incorporated into day-to-day practice at all. It's not incorporated into handoffs. It's as a psychiatric consultant throughout the hospital and in the outpatient setting, I frequently meet clinicians who have no idea about certain aspects of the patient's circumstances that are documented in various places in the medical record, but are not incorporated into kind of how we interface with patients. It's much too problem solution focused at every step along the way.
And for those of you who are in clinical practice, do you feel like part of this disconnect with the integration around the social determinants of health is it a time, or is it a staffing, or is it not sure how to approach that conversation with the patient? Because I mean, that's some of those elements for social determinants of health can be very loaded and fearful from a patient perspective.
Yeah, this is Kate Courtwright. I think it's all of those things, Kate. And it depends on the person, but I think Don really hit the nail on the head as well, that it was an afterthought. The social determinants of health tab and concept of embedding that in the EHR was not how the EHRs were designed. And clinical practice is rapid, it's busy. And so they're aiming, the clinicians are diving right into the clinical aspect of the EHR. And it obviously depends on your specialty, how attuned you are to the importance of your patient's social determinants of health and psychosocial needs. As a palliative care physician and ICU physician, I know that is absolutely pivotal to how I communicate, interact, how we need to support patients and families. It's front of mind for me, but it's certainly not for all. But I think there's ways that we not only have to train our clinicians to keep it front of mind in the next generations, but we also have to, again, sort of leverage the EHR, this thing that clinicians spend the vast majority of their time in front of. We could really use it better. And again, I don't know that we know exactly what we're capturing and how we're capturing it correctly. So part of it's not filled out because maybe they don't know how to ask, but also we're not even sure what we should be putting in there all the time. And we're not trained how to do it. Frankly, it's often a unit clerk or an admissions officer, asking sort of a checklist of questions and nothing behind it, and no meaningful conversation.
Do you think there's also possibly a disconnect because the physician has fear of, if they check, say, housing support needed or nutritional support needed, that what happens next? What do they do? It's not exactly like you can pull out your script pad and write a prescription to help pay somebody's rent. Do you think that those are conversations and infrastructures that really need to kind of be built?
I don't know if other people have
I'm sorry. Anybody can jump in. And I also just wanted to let everybody know too that those of you listening in, you can put questions in the chat. Selfishly, I will keep asking this fabulous panelist all the questions that I want to know, but I want to share them with you. So if you have questions, Ashley will be jumping in to share them with the panel. Go ahead, Don.
So Kate, I was just going to say that I don't know if this is true in other institutions to the extent that it is here, but I also think that we took a wrong turn probably 20 to 25 years ago by reorienting a lot of social workers from traditional social work, which addresses all the things we've been talking about, and focusing on kind of disposition planning, right? And throughput in the hospital. And the needs didn't go away, but our attention to it shifted. And it's really interesting to see how many programs are now within our center, hiring their own social workers to do this kind of work that used to be part and parcel of hospital social work care. And so it's kind of inspiring to see that, but I do think that it was short-sighted on the part of a focus on efficiency in the hospital. And these things are important, kind of planning. People need to be in the hospital for only as long as they need to be in the hospital. I get that, but it's not just about finding a place to go. It's about finding a place to go with the right kind of supports to keep people from coming back into the hospital.
Yeah, I agree with Don, and I want to also add that part of the problem is role of the social work is not well defined in different institutions. At one institution, financial navigator can basically take the role of everything. Other institutions, pharmacists take care of medication, and copay assistants, social worker only take care of the dispo. So it's so scattered, like in terms of the role of the social work, and then who gets referred to them. Some institution is just by request only from the patient. Some institution, if the referring physician refer to them. So we don't have a specific protocol. I think we need to standardize this as a care across all different institutions in the country. As far as who needs to be, every patient probably needs a referral if, they are diagnosed, for example, with cancer or any sort of disease that we think that they have expensive medications coming up that can affect, their care. Or going back to what Kate and Don was saying about the social determinants of health, maybe that should be incorporated also as part of that screening that we have in terms of referring to the patients. So I think that's one of the other research gaps. Just speaking of what is the problem, I think that's one of the other research gaps that I see usually in institutions.
So I'm going to jump over to Ashley so she can start to let us know any questions that the audience may have posed.
Yes, perfect. Awesome discussion so far. One of our questions from Wanda says, as a part of you all's research, would you consider studying the impact of potential high healthcare costs, and would that have an impact on the patient's behavior regarding how compliant they are with care? I'm seeing some head nods, so I know there's some answers to that question.
Why don't we let Courtney kick that one off?
I'm happy to. I actually just finished a research project using CRCAPS data, looking at about 10,000 different cancer patients and trying to understand really the trajectory of out-of-pocket costs that lead to prescription medication non-adherence in cancer survivors. And we did see that individuals with higher out-of-pocket costs have higher rates of medication non-adherence. So these things are important. Cancer-related financial hardship not only is just an issue within clinic, but is an issue outside of clinic and can affect individuals with cancer, both medically as far as their outcomes and also non-medically in giving up, basic necessities, rent payments, groceries. So yes, these things should be looked into. And as a scientific community, cancer-related financial hardship has been studied a good amount. And I think the science is really now moving forward to trying to understand how we can best intervene to prevent these types of adverse patient outcomes that we found to be associated with cancer-related financial hardship. So hopefully we can work towards solving this issue day by day.
Anyone else want to jump in? Or I'll have Ashley move to the next question. Going once, going twice. Ashley, you're on.
Awesome. Our next question comes from Tony K, and she asks, do any of your medical centers offer charity care? Are there any financial resources that can be offered to patients that need that type of support?
I can start. Short answer is yes. The University of North Carolina is a state hospital. We don't turn anyone away because of their financial circumstances, and we have a very robust charity care program. Part of what drove us to begin the financial navigation program was a pretty remarkable finding, which is we got data internally that demonstrated that fully 2/3 of patients in our cancer hospital who begin an application for charity care do not complete that application. And on the one hand, that's a huge number, since, assuming a large percentage of them would qualify for charity care in our place. But on the other hand, it's not surprising when you think about what's involved when you're acutely ill and how hard it is to manage just everything. And so that's when we realized that this is a resource that's available that is not being fully taken advantage of because people need help to do it.
It's the same at Emory University. I mean, we are a private hospital, but we do have charity care, and we don't also turn any patient back regardless of what type of coverage they have. But we do have the same problem. It's a lot of paperwork to complete, especially when you're diagnosed with something that you're dealing with the treatment and all the consequences of that disease, and you're now being expected to fill out paperwork. Actually, as part of the work that we were doing with PAF, all of these brain cancer patients are being offered charity, and we have a financial navigator seeing them. But despite that, PAF, because of their continuous follow-up with these patients, was still able to help with these patients in terms of death relief into some extent, which again echoes that you don't want to just give the paperwork to the patient and leave it on the patient. You want to walk the way with them.
That's awesome. And another question that we had come in by Jessica Jones is, have you all seen any programs that really utilize community health workers to be a part of this process, to kind of lift that weight off of clinicians, because we know that there's so much that we're asking of them with the chart review and handoffs. So have you all seen where community health workers are involved in this?
Yeah, this is Kate. I'm very fortunate at Penn that one of the leading researchers around community health workers, Shreya Kangovi, I trained with her and she works alongside me at our research center. So she has been running several successful trials and community health worker programs expansion, both locally in Philadelphia and around our network, but then has expanded. And I mean, I have to say, short of really focused work around post-discharge for keeping patients with heart failure out of hospital many years ago by a woman in our nursing school, I have not seen sort of care delivery impact the way we have with the community health worker programs. It is profound, and she has lobbied in Congress successfully based on her research to expand community health workers, which I think just speaks to exactly what we're all doing here today, which is to say that, we're just not, all the therapeutics and all the buildings and clinics in the world just are not going to solve the healthcare problems of patients and caregivers without engaging people in the community, meeting social needs. It just isn't, we're not going to move that needle and make care better and outcomes better without it.
And how do you all recruit for patients, to be a part of this work and make sure that the recruitment is inclusive and equitable at the same time?
That's a wonderful question because, I can say that as a psychiatrist, I'm used to talking with people about very personal things, but there are few things as personal as finances. And a lot of people are reluctant to share their financial circumstances, either because they're embarrassed or because there's maybe some suspicion about kind of what will be done with that information. And so it's a challenge to do it in a way that is inclusive. My personal opinion is that systematic screening is the way to go, that gets incorporated into routine care of patients in whatever setting that you're in. This is how we care for people, is that we want to ask some basic questions to find out whether this is or is not a problem. And then if it is, well, we can intervene. And that way we're not waiting for people to raise their hand and saying, and tell us that they are struggling in one way or the other. There are a lot of problems that people will not volunteer unless asked specifically about.
Also, I want to emphasize the role of lay navigators and patient advocates in the hospitals. I guess they are great resources when you want to recruit, especially if you think about recruitment from minorities or people from some sort of different cultures that they need a little bit of more, trust into the health system to be recruited into such research projects. And in that cases, having a patient advocate on the team, or a person who has either experienced the disease or knows that culture, and that way, gain the trust of the patient is very important.
I also think that speaks to the strength of the research done at PAF. They are an organization that has connected with individuals and established trust. And in that way, we're able to hear these patient voices in ways that maybe in clinic we're unable to. It's pretty well known that a lot of times clinical research is not technically generalizable to the whole patient population because we're ultimately missing some of the most vulnerable patients. And so this really, again, speaks to the strength of the research done here at PAF and allowing these patients' voices to be heard and to be ultimately used for big policy changes.
I love what you all mentioned about trust. That is something that we talk about here at NPAF and PAF. Trust is so much at the center of all of this, and trust from all sides, not only just patients, trusting their providers, but also providers trusting their patients. And when we talk about earlier, Catherine, you mentioned how patients and caregiver partners, they interpret the data, but what is that next step? How is that data then translated into policy to make real major systemic change?
Yeah, that's a great question. So I did get a degree in health policy research, and yet sometimes I feel like even though I'm doing real world trials and engage patients and caregivers in our work and trying to make sure we're studying it in diverse health systems and hospitals, I feel so far away from changing policy at times, because it feels like an impenetrable machine, if you will. In my field in palliative care, we have a really amazing national advocacy organization called the Center to Advance Palliative Care. They have many policy tables in sort of many settings. And so I engage them and rely on experts with that kind of language and connections to help take our interpretation, our translation of findings, which again, if they're close to the real world, they're closer to then being able to impact policy. But I struggle to imagine moving the machine of policy along, but I've seen it happen. So community health workers is a great example. There was recent policy changed around community health workers based on research, as I shared, done by colleagues of my own.
Courtney, from your perspective, especially being more on a back-end data side, what are things that collectively we as this community on this panel, what can we do or ask or cultivate in terms of building data that we can then use to support some of these, policy changes or policy asks, again, specifically around this concept of social needs, navigation, and social determinants of health?
Yeah, I think ultimately we just have to use the patient voices. And that starts from pre-diagnosis of cancer to end of life throughout the continuum of care. So really understanding the trajectory of patient experiences in specifically related to their finances, their social needs, while receiving cancer treatment, during survivorship, and at end of life. If we could just collect, that type of data longitudinally, not just a snapshot of picture, or a snapshot of what they're going through, but really the whole experience, I think that would help move the research forward and really get to what the patients prefer and need during their cancer care.
Awesome. Well, this was such a robust discussion. I just want to say thank you to all of our panelists, all of our participants, all of the questions, and most importantly, also all of our sponsors. This is a wrap on day 2 of our Patient Congress. And thank you all so much for your understanding and support while we work through some technical difficulties. We will make sure that all of you receive copies of all the slides and recordings from today so you can go back and rewatch. We will also ask that as you close this out, you will receive a survey. And please, please put your feedback in there. Tell us what was your favorite session. Tell us what really was some information that energized you, so you can take back to your community, because we really want to know. And tomorrow morning, we will start our final day at 11:45 a.m. Eastern Time with a presentation of the Donna Gwynn Outstanding Volunteer Award. So please join us at that time and have a good evening.